Hello everyone, I'm Haejung Kim from Samsung Medical Center. Today, I will present our study entitled Retroareolar Intraductal Lesions Detected by Screening Ultrasound in Dense Breast, Malignancy Rate, and Predictive Imaging Features. Ductal abnormality are increasingly encountered in breast ultrasound practice. In the virus 5th edition, abnormal ductal change was mainly described as irregular ductal dilatation associated with parenchymal masses. However, in the updated virus of 2025, duct changes are defined more broadly as dilated ducts with or without intraductal contents. But isolated ductal abnormalities are uncommon, with reported prevalence of only about 0.6 to 2.9% on screening or diagnostic ultrasound. Among these ductal abnormalities, intraductal lesions refer to non-mobile intraductal echoes or discrete masses within a duct. These lesions can represent a wide pathologic spectrum ranging from benign ductal changes to high-risk lesions and malignancy. Previous studies have shown that the malignancy rate of intraductal lesions vary by clinical setting. In symptomatic women, the reported malignancy rate is relatively high, around 16 to 18%. In contrast, in asymptomatic women, the malignancy rate is much lower, generally between 0 to 4%. Previous studies have suggested several features associated with malignancy, such as symptoms personal history of breast cancer, lesion size greater than 1 centimeter, and completely filled the duct or extending beyond the duct. With the increasing use of supplemental screening plus ultrasound, ductal lesions are being detected more frequently, especially retroareolar intraductal lesions are often encountered, but they can be difficult to assess because ducts converge in this area and benign ductal changes are common. In asymptomatic women, many of these lesions are benign, so deciding between biopsy and imaging follow-up can be challenging. Also, imaging features associated with malignancy are not well established. In this study, we had two main objectives. First, we evaluate the malignancy rate of retroareolar intraductal lesions detected on screening breast ultrasound. And second, we investigated imaging features associated with malignancy in asymptomatic women with dense breast. This was a multi-center retrospective study conducted at three institutions. We reviewed 10 years of screening breast ultrasound data in asymptomatic women with mammographically dense breast. Intraductal lesions were defined as abnormal findings within a dilated duct, including non-mobile intraductal echoes or discrete intraductal masses. The retroareolar region was defined as the area within 2 centimeters of the nipple areola complex. After exclusion, the final study population included 550 intraductal lesions in 544 women. All patients underwent whole breast handheld ultrasound and mammography either on the same day or within 3 months. Three breast radiologists independently review the ultrasound and mammography findings according to the ACRR's 5th edition. Before the review, they completed a training session using 100 representative retroareolar cases. On ultrasound, we assessed background echo texture, multiplicity, lesion size, echogenicity, vascularity. Intraductal appearance was classified as partial fill, complete fill, or beyond the duct. This slide shows representative ultrasound appearance of intraductal lesion. We classify the lesions into three patterns. Partial fill appearance means that the lesion only partially fills the duct. Complete fill appearance means that the lesion completely occupies the duct lumen. Beyond the duct appearance means that the lesion extends outside the expected ductal boundary. Additional ultrasound features included ductal wear thickening and vascularity on color Doppler ultrasound, which was categorized as absent, low, or high. On mammography, we assessed calcifications, asymmetry, architecture distortion, and breast density. In addition, we performed a separate reader study to evaluate inter-reader agreement for major sonographic features. For this analysis, three breast radiologists who were not involved in the main image review independently assessed the ultrasound images. We also collected clinical pathologic data, and the final diagnosis was based on histopathology or at least 2 years of imaging follow-up. All analyses were performed on a per lesion basis, and the following statistical methods were used. And this is the result of our study. As you can see in the table, the overall malignancy rate was only 3.8% with 21 malignant lesions among 550 intraductal lesions. Most of the lesions were benign, accounting for 96.2%, and most of them were intraductal papilloma. Among the malignant lesions, the majority were DCIS, and only two lesions were invasive or microinvasive carcinoma. This finding indicates that retroareolar intraductal lesions detected during screening ultrasound have a low but non-zero risk of malignancy. Clinical factors including age, family history, personal history of breast cancer, and prior high-risk lesion did not significantly differ between benign and malignant lesions. Also, background echo texture, lesion multiplicity, and mammographic density showed no significant differences. In contrast, malignant lesion more frequently showed suspicious ultrasound features, including beyond the duct appearance, associated ductal wall thickening, and high vascularity on colon Doppler ultrasound. On mammography, malignant lesions were more likely to show positive findings such as mass or calcifications. However, most of the intraductal lesions were mammographically occult. In multivariable analysis, two ultrasound features remained independently associated with malignancy. The first was beyond the duct appearance with an odds ratio of 11.4, and the second was vascularity on colon Doppler ultrasound with an odds ratio of 10. These two features were main independent imaging predictors of malignancy. The two independent ultrasound features show different diagnostic profile. Beyond the duct appearance was highly specific with a specificity of 99.1%, but its sensitivity was low at 14.3%. This means that when present, it is a strong suspicious finding, but many cancers may not show this feature. In contrast, vascularity on colon Doppler ultrasounds was highly sensitive with a sensitivity of 95.2%, but its specificity was relatively low at 41.2%. Therefore, vascularity may be useful for detecting malignancy, but it may also increase false positive in screening setting. A 57-year-old woman had an isoequic intraductal lesion extending beyond the dilated duct with prominent vascularity on colon Doppler ultrasound. Mammography also showed a corresponding mass with calcifications. The final diagnosis was invasive ductal carcinoma. A 38-year-old woman had an isoechoic intraductal lesion partially filling the dilated duct. There was no vascularity on colon Doppler ultrasound, and mammography showed no suspicious finding. The final diagnosis was intraductal papilloma with usual ductal hyperplasia. In conclusion, Retroareolar intraductal lesions detected on supplemental screening ultrasound in asymptomatic women with dense breast showed a low malignancy rate of 3.8%, and most malignant lesions were DCIS. Beyond the dark appearance and vascularity on colodoppler ultrasound were the main imaging features associated with malignancy. So the management should balance the low but clinically relevant cancer risk with the need to reduce unnecessary intervention. Thank you for your attention.